All right.
Yeah, well, good afternoon. Thank you guys all for joining us. My name is Jody Brockman. I'm a nurse at NKC Health. I am a coordinator in the Community Health and Wellness Department, and I am very excited to be able to introduce our speaker today for the neuromuscular massage therapy for pain relief. His name is Kirk Nelson. He is a highly credentialed massage therapist based in Weston, Missouri. Kirk and his wife Julie have owned Touchwork of Weston massage therapy and precision neuromuscular therapy since 1998. So we've got a wealth of knowledge from Kirk, and I'm going to turn it over because I'm very excited to hear what you have to say. Just on a side note, I do have the Q&A and the chat open. So if anybody has any questions or any comments, feel free to just drop them in there and I will share them with Kirk.
All right. Thank you very much, Jody, and thank you to North Kansas City Health. I appreciate the opportunity to share some thoughts with y'all. Sort of a pre-summary here. We're going to be talking about pain of and by itself and some of the what I would call more traditional treatments for that, and then how neuromuscular therapy and massage therapy in general can be a in addition to that. I don't want to say a substitute for. I honor what the healthcare system does, and so I'm personally thankful I had my dad for many additional years because of the expertise of those people. So, and speaking of such things, my disclaimer up front, out of my scope of practice to diagnose or prescribe. So, if you have any questions about what I said, that's a good time to talk with your healthcare practitioner. Some of my background she's talking about, I've been a full-time massage therapist for over 28 years. And in private practice, my wife, Julie, joined the practice in 2005. So she has over 20 years in. We do anything from general relaxation and restorative sessions to working with people immediately following major surgeries. We do prenatal to hospice. And we're both board certified. I'm also an approved continuing ed provider for our national certification board. Um, we're licensed in both Missouri and Colorado. I'm former president of the Missouri chapter of AMTA, former state director of the Missouri Sports Massage Team, which was the winner of the 2003 Most Outstanding Sports Massage Team from AMTA, and also a former national committee member and trainer for the Massage Emergency Response Team, which sounds sort of weird, but these folks were designed to go out to disaster sites and work with the rescue and recovery workers in a support role to keep them up and running. And for that, I did receive the 2001 Disaster Service Award from the Virginia Department of Health for exemplary service at the Pentagon following 9/11. And just on a completely different stage, my wife and I are also the co-founders of the Weston Community Theater. So wear a couple of different hats there. And all that and $5 still doesn't get you a coffee at Starbucks. So here we go. We're going to start off talking about a little bit about pain itself. And bottom line on that, pain is still a mystery. There's so much we still do not know. And here's sort of a description that the International Association for the Study of Pain says, and I'm going to read this so I don't screw it up. An unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Yeah, and so basically, unless there's something like a medication or something like that is blocking this pain, a person is in exactly amount of pain that they say they are. Um, and we sort of categorize it into two different sections of either acute pain or chronic pain. And acute pain is sort of like when it says fire, fire. No, oh, no, no, really. And it's like it's an alarm that's warning us to discontinue a particular activity. I mean, and it's useful, it's necessary, and even potentially life-saving. And that's why you have your sensory nerves. The other category being chronic pain, and this is where it really gets sort of messy, because that's more of like fire. Well, at least I think there was one once, maybe. Um, it's a lot of times it's that alarm that continues to shriek even though there's no visible flames to this fire. And ironically, with all of the amazing technology that the medical world has come up with, and which just astound me, but still in today's time, the most sophisticated measuring tool we have for pain is the 0 to 10 smiley chart. And so, and something interesting things about pain too is like pain and fear both live in what they call the middle brain, which is the mammalian brain, i.e. mammals. You have the lower brain, which is the reptilian brain, and then you have the mammalian brain, and then you have the cerebellum, which is the human brain or the thinking brain. And what they have found through using functional MRIs, that if we get to a certain level of pain and or fear, the body starts shutting down receptor sites in our thinking brain. That's why it's so hard to communicate with someone that is in a lot of pain, because because the body has started shutting these down, because it's a survival technique of, hey, you can think about it, categorize it, analyze it later. Right now, we just need to deal with it. So be quiet. And as things calm down, then these receptor sites will start to turn back on. And I also talk with my clients about there's three basic spheres of pain or stressors. You have physical, which is, you drop a brick on your foot, ow. Emotional, yes, we've all experienced that sometimes in our life. And also chemical stressors. And yes, heroin counts, but it also can include hormones, it can include diet, all sorts of different factors, environmental chemicals. And the interesting thing is these three spheres don't work independently. They influence each other on a regular basis, both in the negative and also, luckily, in the positive. So sometimes if someone is having a challenge in one of these spheres, by focusing on one or both of the other two, you can have a positive influence on the one that you're challenged with. So that sort of gives a basis of the thought process of pain and how it works. Now, some of the more, I guess I would call traditional approaches to treating pain, the most common are either, pharmaceuticals or procedures. Most commonly, but not exclusively, physical therapy and or surgery. Biggest benefits of over-the-counter medications and prescribed medications is that it can create a very quick and efficient results. And it's also a low initial cost. I mean, ibuprofen, Tylenol is not going to break anybody's bank account. Some of the biggest challenges is sometimes healthcare practitioners have some fairly serious time restraints. So they're having to basically prescribe, this is what works best for most. And challenges of that is it may not address or resolve underlying causes. It becomes a masking of that is just treating the symptom and not necessarily the cause. And you also have some complications and costs of, opioid additions, if we're talking about the more powerful. And opioids definitely have their place. But no big news that, we did and are still dealing a little bit with the impacts of the opioid, what they're calling the opioid epidemic. On a positive note, an economic impact of including massage therapy to treat pain. There was a wonderful report put out in 2017 by the American Massage Therapy Association. And again, I'm going to read here so I get it correct for you. According to the Joint Commission and the American College of Physicians, non-pharmacologic approaches or techniques like massage therapy can replace opioids for many types of pain. John Dunham and Associates calculates that number to be as many as 5 million patients in the United States, less than 20% overall, with the potential to reduce the number of people with addiction disorder by nearly 112,000 people per year. This projection suggests providing massage therapy as a tool for pain management instead of opioids can save the United States as much as nearly $26 billion a year. I mean, that's powerful. After a while, you start talking about real money. And partly why massage therapy has become more popular for treating pain, other than, addressing what we just talked about with the opioid epidemic, is one, there's been an increase in research. We're still in the infancy stage of research for massage therapy as compared to other healthcare fields. But it's getting much better. A great resource for that would be the Massage Therapy Foundation. They fund a lot of resource, and they also have links to where you can find additional research projects. We're also soft tissue issues. That's right in the middle of our wheelhouse as massage therapists and neuromuscular therapists. And God bless, physicians, they have to know so much. I don't even know how they do everything that they do. But honestly, it's like they don't get a whole lot of education on soft tissue. And, the number of people who come to their physician with soft tissue pain is a fairly good chunk. So, that's where we're getting more and more referrals from physicians for this. We do have the advantage of taking a little bit more of a holistic approach. And because a lot of times I'll have somebody that comes in with the shoulder issue, but finding out that shoulder issue is because there's obliquity in the hips, which is they're just out of balance, or maybe even something like a fallen arch. So being able to step back and look at that in such a way so that it's amazing how many times the solution is not where the presentation is with our work. And generally less painful than a lot of other approaches of that, and we're always talking with our clients of on that 0 to 10 discomfort scale, please don't let us get above a 4, because more recent research has shown anytime it gets above that 4, the results start plummeting. Because if the tissues think we're trying to hurt it, they're going to tighten up to protect themselves. That we're just sort of hardwired there. And so then, so you're looking at a situation, as an example, we say is if somebody swings a baseball bat at your stomach and you see it coming, your abdominal muscles will tighten automatically. You don't have to email them or anything. Sort of cool. Very necessary, but sort of counterproductive to what we're trying to accomplish. We get more one-on-one time. That's one of the things I'm so grateful for. We're one of the few healthcare providers that actually get to spend an hour or an hour and a half of one-on-one time with our clients. This gives us time to explain things. This gives us time to listen to their story. I used the example of a gentleman one time, again, came in with a shoulder issue, no known cause, but through casual conversations while we're working, he started complaining that, I wish my next door neighbor would hurry up and get home from his Europe trip because, he's tired of walking his dog 2 or 3 times a day. And I said, "Oh, what kind of dog?" And he goes, "A Great Dane." And I said, "And what arm do you hold the leash in?" And he goes, and he goes, "Oh." All of a sudden he knew through casual conversation what was causing that shoulder issue. And, lastly, and it's still a raging debate within our profession, but, most of the massage therapists in this part of the United States do not accept insurance, but that also means that we're not constrained by insurance. And I'm personally grateful for that. It's like, because I have the ability to treat by what's needed versus needing to treat by what's covered. That's just my personal thought process there. Now let's get into a little bit of sort of typical approach to treating pain in our world. First, and this is sort of my personal, everybody's a little bit different. And by the way, so I got some wonderful advice early on saying, we need to get in our massage therapy world, we need to get away from treatment-based education and get back to strategy-based income, because there's well over 200 different modalities of massage therapy, and they all work. But as he said, he took his finger and pointed onto his own arm, and he said, and held it there, and it says, how many names do we need for that? So that shifted my whole thinking. And so the very first thing I do is I want to gather in data, both written and oral, things that we're looking for. Where is the exact location of this pain? What's is there an onset time? When did this happen? Sometimes they can't remember exactly. Um, there's also, is there any known causes? What's the severity of the discomfort? Notice at this point, I switched from saying pain to discomfort. And actually, I prefer that word simply because I've had a lot of people say, hey, I asked them, say, how painful, what kind of pain are you in? And they would respond, oh, no, I'm not in pain. It just hurts. And it's like, I'm sort of scratching my head. And it's like, huh? So now I use the word, what's the severity of your discomfort? And that sort of keeps both of us on the same page there. I get much better responses with that use. I'm also looking at, I want to know what daily activities or movements or approaches that they have used or done that either exasperates this discomfort, or I also want to know, what do you do to relieve it? Is it rest? Is it moving it? Is it using some over-the-counter medications? What's helping? What's hurting it and what's helping it? And asking them things like what past, current, or future treatments have you done or considered for this condition? And how are they effective or not effective? And have they been under any recent life changes or additional stressors? And then the last question I'm, asking then is, what's your goal of this session today? When you walk out my door, what are you hoping? And sometimes we need to put it in such a way that explain to them that if they've been dealing with this for a year or more, that them becoming completely pain-free in one session might not be realistic. So it takes a little while. If it's something that just happened a couple of days ago, we might be able to do that depending upon the severity of it. So we want to make sure that we have some realistic goals between the two of us. Next step is assessments. And a lot of times, if it's, again, I'll go back to, well, I'll change it. If it's a hip issue, then the first thing I want to do is I want to see what's going on with the good hip, assuming the hip issue is only on one side. And then that helps me sort of establish a baseline. That way I can go over there and I have a good idea of what that good hip can do with, movement and resistance and strength. And then I go over to the one that is in trouble, and then I'm going and it's like, oh, yeah, it can. Oh no, it can't do that. So then I'm looking for those differences between the two sides to hopefully get those back in balance. The things I look at and do during assessments is like, one, I'm looking at their overall posture. And I'm looking for strength. I'm looking at what their range of motion is. I'm looking for specific painful spots and or movements. As good as, like, it's fine when I do this, but it hurts when I do that. Aha. Those are all giving me clues. And is there referred pain? When I press here, does it just hurt here, or does it refer pain to somewhere else? That way we're looking, are we looking tender spots, or are we looking at trigger points? Is also seeing if there's any visible bruising, or maybe even temperature differences. Acute pain, a lot of times will come with inflation. Inflation? Inflammation is the word I was looking for. And so that tissue is going to be warmer than the surrounding tissues. Many times with a chronic condition, that tissue will actually be cooler than the surrounding tissues, because if the problem area is hypertonic, i.e. too tight, then you don't get that same transference of fluids. And so, it reduces blood flow to the area, so it cools down a little bit. So those are basically what we're doing. We're looking for differences. And all these things start giving us clues as to what our next step is going to be. And speaking of, it's like now we're trying to figure out I lost my pages. Oh, there we go. I'm sorry. And then we're going to create and implement that treatment based upon the data assessments. Sort of, is it the best to go straight to specific work? Or is it better to calm down the whole system first? And this can vary from person to person and case to case. It is a lot of times, if they're really in an acute state of pain, sometimes it's very advantageous to just calm everything down a little bit, so that the body then will allow you to come in and do this specific work. So many therapists, they just want to dive right on in, and now you're just creating one more trauma on top of everything else. This is sort of what I call the difference between working with the body instead of working on the body. Because you do have things that are going on. There's facilitated pathways with the nervous system and everything like that, which we'll get into a little bit here. And then you sit there and then you're looking at muscles, tendons, ligaments. That's, sort of our wheelhouse, right in the middle of it. And when you're working with muscles and tendons and ligaments, it's a little bit more specific. You have trigger points versus tender points, which we talked about, is that the difference of whether there's a referral or not. And then one of the things that we look at is like, okay, this muscle isn't working well. It's not moving the bones the way it's supposed to. Is it true weakness in the muscle because there's too much tightness in the muscle, or maybe there's a tear? So that you don't have access to the entire muscle, versus is it being restricted from the antagonist muscles that are too tight, which some of that weakness of what you were thinking of as weakness is muscle still good, but it's not only has the job now of moving the bone, but it's also being has to fight a tight muscle on the opposite side. And so we see that a lot. So a lot of times going in and working the opposite side is more important than working where the complaint is. And we see that a lot with an example might be with somebody coming in with sore neck, shoulder in the backside. We see that a lot with the computer dwellers and phone masters, because they talk about the head weighing about the same as a bowling ball, but that the laws of physics tell us that for every inch it's forward is the equivalent of adding the weight of your head one more time. And when you're wrapping around at the shoulders, it brings the head forward. We've all seen these people. But again, once again, the solution isn't necessarily where the presentation is, because what happens is when it's out there like that, now instead of holding up a 12-pound head, it's the equivalent of trying to hold up a 36-pound head. And all those posterior muscles are getting very weary. They're getting weak because they've been trying to keep that noggin from hitting the screen for hours on end. And they get grumpy. And more times than not, in those kind of situations, it's the stretch type that yells first and loudest, where we turn around and on the front side, these muscles like the SEMs and some of the scalenes and some of the other anterior neck muscles, they become adaptive shortening. So then now they are fighting. So it's a lot of what we need to do is to lengthen some of these muscles in the front to take the pressure off the back. And then we go and calm down the posterior muscles. So that's a little bit about some of the approaches that we take with muscles. And I always recommend people, you work general to specific and then back to general. Sort of like giving a speech sometimes. It's like you tell them what, you do introductions, you get into the meat of it, and then you give a summary at the end. So now fascia is a little bit different. My standard fascia speech, and if this is a little simplistic for healthcare professionals at this point, is like, this is what I tell my clients. I'd say, hey, have you ever heard of fascia or fascia, tomato? Well, it's like, when you skin a chicken, just underneath the skin, there's that layer that looks like saran wrap. That's fascia. Or you have the little boy that takes that slice of roast beef and pulls it apart so he can see all the little circles. That's fascia. It wraps around every single muscle cell, wraps around groups of muscle cells called muscle bundles. It wraps around muscles itself, wraps around groups of muscles, wraps around organs, wraps around bones, wraps around the whole body. It's sort of our matrix, if you will. And very strong stuff, tensile strength equivalent to about a tow rope. That's why everybody in their life at some point has to take that one piece of meat out and put it back on the table. We call it gristle. But the cool thing about this is that as strong as it is, but it has a gelatinous coating to it, which is what allows this part to stay still while this part slip slides. And that's how it works. So, but due to physical, emotional, or chemical stressors, or any combination thereof, like we talked about before, fascia has a really nasty habit of dehydrating. Then instead of a gel, that coating becomes more like a glue. And that's what we call fascial adhesions, or sometimes in Missouri, we just call it stickage. But so it responds very, very well to moist heat. I prefer that they don't use dry heat, because the problem is dehydration. The heat will help melt it, but we don't want to take any chances of dehydrating it further once it cools down again. So moist heat, that can be something as simple as a washcloth or a hand towel, depending upon the size of the area. And which then you put it in a microwave, get it hot, not so hot that you can burn yourself, obviously. You put it on there and then put a dry towel over top of it. Very simple procedure. Nothing to buy. And you can even travel with it because most hotel rooms, they have hot water. So that and now how do we tell the difference of whether it's a muscle tendon ligament issue versus a fascial issue? That muscle things like trigger points, they're like the size of a small grain of short grain rice. If you get just a few millimeters off of it, you're no longer on it. So it's a very specific pain. That's when your client's like going, well, that sort of hurts. Ooh, right there. That will be more of a muscle or tendon or ligament issue. Whereas fascia, it sort of hurts here over this big broad area. And it's like you're looking, it's like there's no muscle that goes from there to there. So that's when, and a lot of times if you do have a muscle issue, there's going to be a fascial component to it. One of the things we do as massage therapists, we do skin rolling. We're just lifting that skin and rolling it with our fingers to separate the skin from the superficial fascia a little bit. It's not the most comfortable thing. It's a little pinchy. That's what you will hear. But then when you're done, you can go back and do that skin rolling again. And they're like going, that doesn't feel bad at all. It sort of feels good on healthy tissue. And that's sort of what cupping is about. I prefer to do skin rolling because I don't see the need to break a bunch of capillaries when you can do it in a different way. That's just personal thing on it. And then the final one there is neural. And that's probably the most challenging for massage therapists because it's like basically we're looking at that point of trying to locate and treat potential impingement areas. Because nerves love to move. Nerves hate to be stretched. So, if your nerve is going like this, it's going to get grumpy. But what they call nerve flossing is when you shorten one end while you lengthen the other. And that does wonderful things for it. Like I say, where we do a lot of is looking of where can we open up some of these muscles, soft tissue that might be impinging and i.e. pinning that nerve, creating a stretch. A classic one is with sciatica. We're gonna look at that piriformis muscle because that sciatic nerve goes right underneath it. With carpal tunnel syndrome, you got the median nerve. But then there's also different places that can get pinned up in the neck. It can get pinned in the brachial plexus. It can get pinned in the forearm with the pronator teres. And it'll all refer down to carpal tunnel, through the carpal tunnel to the thumb and the first couple of fingers there. And so we're looking that way. And as far as nerve flossing, a lot of times I know some of the basic movements for a few nerves, but this is where I would refer to a physical therapist. It's like, because I have yet to find any place that they can't figure out a way to nerve floss. They got a wealth of knowledge in that area that I really, really appreciate. And then probably the last thing I'd say is it finally dawned on me, we all have those things as we go along our career where we go, gosh, that would have been nice to know like a decade ago. And gosh, I think for every, how would I say this? For every door of knowledge I walk through, it seems like 10 more doors present themselves, which can be frustrating, but also sort of exciting all at the same time. But one of those aha moments, luckily, I learned quite a while back was that, yes, we work with the soft tissue. That's the middle of our wheelhouse. But actually, our conversation is with the nervous system. Because, I mean, otherwise, if it was just strictly a massage, a muscle issue, we just put you under anesthesia and you'd be fine. But unfortunately, when we come out of anesthesia, we sort of go right back to those postural distortions. And the other thing that I do while we're doing these sessions, going through all these different things and treating what is necessary based upon assessments and then what we're finding. And by the way, get all these clues and I think I know exactly where things are. And, I get these great theories. And then when I get into work, as I say, it's like it was a wonderful theory, but then those darn facts got in the way. And so you have to be able to shift gears and say, okay, what's plan B, plan C, plan D? And I also, when I'm doing specific work like this, it's very interactive. I'm usually doing that on top of the linen. So, I tell them bring clothes that you can move in. Because I might have them sit up or stand up and walk around 3-4 times in a session. So I do something that's like, okay, hey, did that, how's it feel now? Okay, so, lay back down, and we'll do this. And then, hey, how's it going now? And so I'm always asking for feedback. I say, let me know about pressure or if just something feels relevant. And so I adjust that, and then I adjust my strategies as needed as we move along during the treatment. And at the end of that treatment, it's about reassessing. Did the treatment create a change? Where is their level of discomfort now on that 0 to 10 smiley chart? Did this change the range of motion? Did this change their strength level? And this is why it's so important to do the assessments prior to the work, because otherwise, how do you know if you don't have anything to measure it from? And because you used to get clients that they'd come in, it's like, okay, it hurts when I turn my head like this. And then after the treatment, it's like, how's it doing? It's like, well, it still hurts when I turn my head like this. And they don't even realize that they gained 35 degrees of movement. So, sharing with them what you're seeing and then sharing with them what you're seeing and feeling afterwards and what they're seeing and feeling and afterwards, that's powerful. And so that's important to look at. And then last thing would be homework. Sometimes it's rest. Sometimes I'll do movement. I don't really recommend a whole lot of stretching anymore. I'd rather them doing gentle movement. And there's that 1 to 2 hour window that if they can keep moving it, not trying to gain any additional stuff, but just letting the body know that they can do that again can really reduce the amount of atrophy from the work. The fancy word is neuromuscular re-education. And maybe I might even recommend trying some contrast hydrotherapy, going back and forth between ice and moist heat to get that speed up that transference of fluids in and out, which can speed up then the recovery time. And then looking at, are we going to do future sessions? What is it? Sometimes it's like, we're going to need to do like 3 to 4 sessions here, and then reassess where we're at overall with the treatment thing. And then, or, it might be just as simply as needed. If it was something fairly minor and we were able to take care of it real quick, go forth, do good things, or, maybe come back so we can smooth out the entire blanket because, hey, if pain anywhere in the body is pain everywhere in the body. And so just creating that overall piece and homeostasis within the body can help it. So that's sort of the roundup of, looking at pain and looking what my colleagues are doing to treat this and how we fit into that picture. And like say, I also, well, there's times it's like I do refer out. There's sometimes because the worst case scenario, are you better? Is the best case scenario? Is it worse? I'd rather have him say it's a little bit worse than the worst case scenario, which is there was no change at all. And if there's no change at all, then that means it's something beyond what I'm capable of. So let me refer you back. Client just recently, pain underneath the scapula. We couldn't get it to change at all. And it says, you need to go back and talk to your physician and say, hey, maybe this is a gallbladder issue, which is what it turned out to be. I could have rubbed on it all day long. It wasn't going to change. With that, I'm open to any questions you may have or anything
Yeah,
you'd like to expand upon.
we've got one here. So you talked about assessments prior to um, the actual session. So is that
Uh-huh.
done over the phone or
No, this
is
is
it?
done. I might chat with them a little bit on the phone when
Uh-huh.
they make their appointment of why they're coming in. But no, the assessments, a lot of them, especially, um, those are done in person. I
Okay,
want to see their face. I want to hear their words.
great.
And
And
then we also have the physical assessments where I'm testing for strength and range of motion, which is definitely done in person.
okay. So how long should they plan on that initial consultation, that first visit? Or is it just case by case?
It is case by case. In a perfect world, I would love to have that first session be a 90-minute session.
Hmm.
Um, but I've had other people, and that's why we sort of say full and extended. The 90-minute is what we call our extended. But because sometimes it's like you get in there and it's like, oh, I know exactly what this is, and I'm actually right for once. And if they're, they don't care about going to La La Land, they just need their arm to work again, and I can accomplish that in 40 minutes. I give them 20 minutes of their day back. It's the same pricing because, I'm not going to penalize myself because I'm efficient. Um, but so it can really vary case to case, but initially it would be nice to have that extra time so that we don't have to rush through everything.
Yeah, great. We've got another question here. Any recommendations for sternoclavicular arthritic pain?
Student. Well, you mean besides myself? Um, I mean, that is, that's a lot of times that, I would from my vision, and sometimes it's good to have um series because different practitioners and different professions, they look through a different lens. When I hear sternoclavicular, what was the last part of that?
Arthritic pain.
Okay. You could be looking, there's certain muscles, the subclavius, there's also might look at some of your scalenes and looking at whether the traps and the lats and the pec major are working properly, that's not putting in additional stress on those areas. That would be what I would be looking at. Now, a physical therapist might look at that in a completely different lens. And I think that would be great to do too.
Yeah. Yeah, she said it's a difficult spot, she knows, unfortunately. So, do you have any success stories that you want to share? Something
Oh,
that would kind of resonate with the general population here.
yeah. We have one of the services we provide is a what we call partners touch, where we go through some of the basics, but then they spend half their time receiving and the other half of the time working with me on their partner.
Mhm.
And that came out of early in my career that it was he was a gentleman that was in probably about 60 years old and still breaking horses.
Oh,
And then one of those horses broke him.
oh, goodness.
Uh, and so his wife brought him in, and yeah, he had multiple things going on there. Um, but and they had limited means. So what I was doing is I was teaching his wife to do some things um, based upon what I found in between our sessions. And it was sort of fun because towards the end of that, I think she was doing more work than I was, and it was probably better work. Uh, you know? But it was sort of nice to empower people, and I was more of working as a guide for them so that they could work with each other. And that's what I love working with these people that are interested in what can we do for ourselves
Oh, yeah.
and sharing the. I mean, it doesn't make them a professional massage therapist or anything like that, but it, gives them a peek behind the curtain.
Right. It empowers them to be part of their recovery journey. That's great.
Yeah. And I think the other success story I think that comes to mind is uh, when Julie was in training. Had a gentleman come in. He was 62 years old, um, union construction worker, and he had the physique of a union construction worker. And unfortunately, he had fallen from scaffolding, 15 feet of scaffolding, and landed on cinder blocks.
Oh, goodness.
And his wife was a client of mine. She finally brought him in after a year. He had gone through all the workman's comp, and they said, "You're fine. There's nothing to go back to work." But he was still in screaming pain a year later, where he was waking up 5 to 6 times a night in screaming pain. Um, and so I said, "Well, I'll tell you what, I'll cut you a deal with the thing that where Julie sits in. I'll be doing all the work, and she'll be taking my session notes, but I will be thinking out loud, so she can know what I'm going through in my thought process." And first few sessions was doing basic clinical sports massage then, and got a little progress, and then it was like, we were probably halfway through the fourth session, sort of, and it finally dawned on me when I talked about facilitated pathways, where sometimes the nerves being electrical and and hydraulic in nature, they take the path of least resistance, and they can confuse whatever the sensation is, it gets misrepresented and sent up to the pain receptors. And so I switched over to just very gentle touch, very slow, light touch, and very broad. No finger work. It was all like palms, just trying to do whatever I could to send a positive signal up the neural stream. And we did the rest of that session. And then we did session number 5. Then that's all I did. Very boring work, but powerful, because when they came back for the 6th session, he looked at me and says, I went 4 nights without waking up at all. And the other 3, I only woke up a couple of times. And this is a couple that hadn't had a full night's sleep in a year.
Wow.
And so, and so that's why I say sometimes, and it's our catchphrase is creating world peace one body at a time. And this is one of those times where that's what set up the ability to then go in and do the specific work. Because prior to that, the body was just not going to let me in. Anything I did, it just interpreted it as additional trauma.
Wow. That's heavy, and it is just, like you said, it can be tedious, but it can be done.
And I'm just grateful that I have the ability and the time to do that.
That's wonderful. Well, we've definitely got some good information from you today, Kirk, and I thank you. I apologize to to our the people that did sign up because the link was not correct, but we tried to email that correct link out. But once we get this presentation, we will have it posted to our YouTube site. So everyone who did sign up will still have the ability to hear everything you had to say. So we will share that, and everyone can share it with whoever they feel would benefit from this information. And again, Kirk, thank you very much for being here with us today.
Well, thank you for the opportunity to share this information.
Yeah, it was great. It was great. You have a wonderful rest of your day.
I will, you too.